I don't think the laser is going to help much actually, because I'm going to have to point at the screen on the back. So good morning everyone, thank you very much for joining us again. Over the next 12 or so minutes, we'll do part 2 of the talk that we started yesterday. Yesterday we learned how to look at calcium with a very careful quantitative eye, right? We don't look at calcium now as it's on the angiogram or it's off the angiogram. We look at it much closer than that now, where if there's an arc over 270 degrees of calcium that is more than 5 millimeters long, that gets a point. That there is the presence of a calcified nodule, that gets a point. If there is reverberations, natural reverberations that are greater than 90 degrees, right? So there's more than an arc of reverberation, that does not get a point. If there are no reverberations, you get a point, right? So reverberations means thinner calcium, okay? And then the length of the lesion and the size of the vessel get a point. So if your vessel is greater than 3.5 millimeters, no point. If it's less than 3.5 millimeters, you get a point. And if you have any more than 1.7 points, so for closest rounding, if you have any more than 1 point, you're almost certainly going to have to modify the calcium to some degree to get the result you're looking for. So if I can get my slides brought up onto the screen, there we go. So let's take part 2 now and start us with a question to our learned panel. We have a number of very learned panel members here. We have many experienced interventionalists in the crowd. And my question to you is, how do you know when an OPN balloon is going to work? What is it that makes you decide you're going to pick that? How do you know what Wolverine is going to work? What makes you, Dr. Maskey, I mean, if you're going to pick an NC balloon to crack a lesion, when are you going to pick an NC versus when are you going to pick a Wolverine? And what makes the difference and how? You don't have to answer here, but the question is a real question that we try to answer every single day. We do this in the midst of our practice every single day, but with what structure? And so my goal over the next 12 minutes is to crystallize that structure a little bit and give you my approach. It's one approach, but it seems to work for me. These are my disclosures. So these are the current concepts in coronary calcium management. There's this algorithm, which is got all kinds of crosses and twists. There's this one, which has got even more. It starts to make your head hurt. And then there's this algorithm that came out by Optima, which looks like a map from the London Tube. It's too complicated. There's too many decision points. There's too much to look at here when you're trying to make careful decisions in the course of managing a complex case. So we need to make this a little bit simpler. This is the algorithm that we put up yesterday. If you have angiographic calcium, then think of your algorithm or your score around whether or not this calcium is going to yield. For that, you need to use intravascular imaging. If you have no angiographic calcium, even though there may be some there, it's probably thin, balloon it and stent it and go. So if you now have angiographic calcium and you've imaged it, let's say you use IVUS and you have the presence of reverberation, so the calcium's less than 0.5 millimeters thick, but there's an arc of over 270 millimeters, right? Or 270 degrees, so you have 2 points. How are you going to modify this? Are you going to use a cutting balloon or an OPN balloon? Are you going to rhodie it? Are you going to use lithotripsy? So let's try to crystallize that and try to make some decisions, make some decision points around how we make these things clearer. These are the open questions that we ask ourselves about these therapies. Which lesions take what balloon? Long lesion, short lesion, fat lesion, small lesion? I mean, you know, it sounds a little bit like a children's song. Which one do you use atherectomy on? Long, short, heavily calcified, moderately calcified? What about safety and pressure advice? Who's comfortable taking an OPN balloon to 35 atmospheres in every lesion? You know, what if this is a 90-year-old woman and you're worried that it's an aneurysmal segment and you're going to tear the artery? What about IVL? Is it going to pass? Can you get it to the site? Is it worth cracking the $3,200 because you think that even though it's going to give you great results, you can actually get it there? How do you line up the emitters to get the best result? How many pulses do you put on every lesion? Do you prep it first? Do you prep it with totally contrast? What's the concentration you use? All of these things are open questions. And of course, the other big question, of course, in our market here is cost, right? Because we've got to consider the various things that are necessary to deliver therapy in these challenging patients. So let's start with an OPN balloon. This is a effectively a Kevlar-coated, double-layered balloon that allows ultra-high pressure inflation. The misnomer is that if you have an underexpanded lesion, you take a bigger balloon. It could not be more wrong, because the area of underexpansion is still touching the walls. What you do is either take a smaller balloon, or you take an OPN balloon at 1-to-1 pressure, and you crank the pressure high, because it's the pressure that's going to create your axial and longitudinal cracks in the calcium that will allow your balloon to expand. So let's take a look at this inferior STEMI for a second, okay? That's an ugly and calcific lesion. And in this case, we wrote at it because nothing would go. The tip-off, by the way, to whether or not you're likely going to need ROTA is if you put your wire across and you can feel grit in the wire is captured by the calcific lesion, don't bother with anything else. Good luck. OAS is not going to pass, IVL is not going to pass, you're going to have to atherectomize it and then use a combination technology of some sort. So we wrote at this, and then we put a 20 atmosphere 3.5 NC balloon distally, and that looked like it expanded. And so we put in a stent, but you can see here now, distally, there is an area of underexpansion there. So how am I going to fix this problem now? Look at the stent boost, right? It's clearly underexpanded at the edges. But fear not, we IVISed this. And what do you see? You see a ring of calcium, but you see reverberation artifact in 2 quadrants. That means this calcium is thin. And that is where an OPN balloon at 35 atmospheres comes in. So circumferential calcification with thin calcium is what gives you a good result with pure high pressure. So going back to our algorithm, we can think about how to fit this tool into the way we treat calcified lesions. I wasn't worried because I know that based on contemporary evidence, high pressure will yield calcium that is less than 0.67 millimeters thick. Okay, you can get that measurement. So if you don't have reverb, it's better to safely assume that it's more than 0.67. If you have OCT, you can measure that out. But if it's less than 0.67 millimeters thick, or your arc is about 220, you can crack that with a high pressure balloon. Just do it and move on. That's how we consider OPN balloon efficacy. It's a function of calcium arc and calcium thickness. So going back to our algorithm now, let's develop this out. If you have a stent, or if you have a calcific lesion with relatively thin calcium, and your stent is underexpanded, this is where I use my OPN balloon. I don't use it up front because most of the time if I've imaged and I've got thin calcium, I can crack it with a high pressure NC balloon. But if I've got a stent in place or I've got thicker calcium in one place and thinner calcium in another, there's your OPN balloon. Okay? And you take it up 0.75 to 1-to-1 size and you go to town. You'll be fine because you have an image to tell you that the vessel's not too small for that balloon. Now let's move towards a cutting balloon. So these are true NC balloons. Right? They are NC emerge balloons that can, everybody from Boston Scientific can plug their ears, that can go up to much higher pressures than they tell you they can. I've taken these balloons up to 24, 26, 28 atmospheres in live cases or not live cases. Many times they work just fine because it's a real NC balloon. They have triangular athertomes on the outside. So what you're doing by putting these things up to high pressures, and the iteration on the flextome was tighter packing and the fact that the flextomes, athertomes were squares. These are triangles. Is when you impart force on a triangular athertome, a smaller unit, you're imparting more force per unit area. So this is make a crack, okay? This device is to make a crack. That's what you're really trying to achieve. You're not trying to obliterate the calcium. You're trying to make a crack in at least 2 places so that you don't get a fulcrum. You can actually allow both halves of the vessel to expand when you put the stent in. So when we look at the actual data around cutting balloons, and you look at cutting balloon plus stenting versus PTCA plus stenting, when it's IVIS guided or when it's angio guided, both ways what you find is that you're going to get better results when you break calcium. Okay, the key is the calcium crack. So let's look at this 61-year-old with a long LAD lesion. Once again, nothing would go, so we wrote at it. Then we put a 4.0 NC balloon, and I took this to 28 atmospheres and went back and forth and back and forth and back and forth, and it laughed at me. But then, after I had imaged, I recognized that there was a physical area of calcification that was nodular, but the rest of the calcium in that arc was thin. And because I recognized that, I was comfortable taking a Wolverine cutting balloon, taking that up. In this case, I took it to 22 atmospheres, got it fully expansive. And once again, if you look here, you'll see that there's a nodule on one side, but now you've got reverb that you're going to see on the IVIS there. See near nodule there. And reverb all around the various cracks in the calcium. Here, 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 right? So with reverb, once again, your thickness is not particularly high. And even though you've got a point for the nodule, the other areas with reverberation are going to crack with a cutting balloon, and you get a very nice result. And you can combine all kinds of these strategies, rota cut, rota plus IVL to give you rotatripsy. Whatever you need is based on the amount and morphology of calcium you're dealing with. So predictors of fracture of calcium with a cutting balloon are a calcium angle less than 200 degrees, so just over 3 quadrants, and a calcium thickness of less than 0.5 millimeters. So 3 quadrants of calcium, even if one side is a nodule, 3 quadrants of calcium that is thin, and you'll get it with your cutting balloon. Okay? So going back to our algorithm, cutting for thinner calcium, stent-in balloon. Or if you have suboptimal crack following rota, or following orbital atherectomy, but you have demonstrably thin calcium in those places, this is your friend. This is when you use your cutting balloon. Now what about Shockwave? This is cool. This is my friend Lorenzo Azzolini. You'll see him put his fingers on this thing, put his fingers on the emitter, and it doesn't actually affect distensible tissue, right? These are impulses of sound going into soft distensible tissue. So distensible tissue doesn't crack. Calcium cracks because it doesn't bend, right? That's how sound waves work. So when you look at a pooled analysis, you can look at the Disrupt CAD3 trial, which had very good outcomes and a lot of good growth on the acute lumen to allow stent placement. Even when you look at multiple trials over the Disrupt CAD series, what you see is that pretty consistently you're getting good procedural success, right? This device does work. The problem is it's hideously expensive and it doesn't get to where you want to put it half the time. So how do you train your eye, or how do you change your algorithm to be able to use this device appropriately? So what we look at is once again, the amount and thickness of the calcium that you're using. So this is somebody who had severe thick calcium who was on Impella support. And this is a major determinant of whether or not IVL is a good choice. If you have individuals where your hemodynamics are concerning, right? If you're a little concerned about doing rota or you don't have access to an Impella, this might be a place where you'll fit IVL into your algorithm because the learning curve is 0, it's pretty safe. And if you can get it to the site, so that's key, if you can get it to the site, you're unlikely to cause hemodynamic compromise with short 10-second inflations, right? So that fits into your algorithm there, right? And what we did here, once again, is we opened the IVL, we tried to put it in and it laughed at us. So we wrote at it and then we put it in. And we got this beautiful fracture result. So you've got all kinds of cracks in the calcium in the LAD, but then if you look back at the proximal LAD here, you'll put your eyes on the ring that comes up, and I'm just going to fast forward this through in the interest of time. There, you've got an ugly calcific ring without reverb across more than just this tiny segment in the sort of 1 to 3 o'clock range, right? So this needs more. So you can upsize the rotoburr, but in this case, the hemodynamics were already an issue. So we used 60 pulses of a 3.5 millimeter Shockwave, got a great result with a ton of crack, and then we've got a minimal stent area of like 12, right? Which is what we're going for. So in the Bangladeshi context, virtually no learning curve, useful on thick calcium, useful with patients with low EF. What are the downsides? It's expensive, it costs a lot, it's difficult to raise the money, it's expensive, and it's expensive, right? And there are some open questions about how to deliver it and you know, working out where to put pulse emitters and how to prep the balloon. So this is a very useful therapy. It is a extremely effective therapy, but it's a matter of us targeting it to the right patient at the right time. Okay, and so that's what this might look like. That's what this looks like in my practice, where if I've stented it and I've got under expansion due to calcium, this is an IVL patient. If I've got under treatment with my first pass of rota, this is an IVL patient. If I've got a bad EF where I don't want to rota, this is an IVL patient. If I've OES'd it, if I've done orbital atherectomy and I've got cracks in some places, but I still have a core out of calcium that's not thin in all 4 quadrants because I remember I want more than one crack, this is an IVL patient, right? So the point of this is to get us away from, let's try this device and see if it'll work. That's not good enough. It's 2022. We're better than that. What we now need to get to is, let's target our tool. Our square peg goes into a square hole. Our round peg goes into a round hole. And in that regard, each of these tools, IVL, cutting balloon, OPN balloons, they all have their own utility targets, right? And so you use those utility targets, those algorithms, to be able to define what it is that you're trying to achieve, which is multiple cracks in the calcium that you're treating so that you can get good stent expansion. So your take-home points: image, 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 image. It does not make sense to do complex cases with one hand tied behind your back. Has anybody ever used the 5th generation drug-eluting stent? Have we seen the 5th generation drug-eluting stent? I mean, we're pretty keen on Synergy or Resolute Onyx or Xiant Sierra or Alpine or Skypoint or all these really good stents. What about the 5th generation drug-eluting stent? There isn't one. It's called intravascular imaging. It has independently reduced heart outcomes by 40%. It is nuts to take all of these other devices and not learn how to use imaging, because that's going to be the biggest change in your outcome. Once you've imaged, use the specific points that we've discussed to be able to target what tool you use to the therapy that you're trying to provide. Recognize that thinner calcium responds to pressure, whether that's OPN because of a larger arc or a cutting balloon because of a point pressure to create multiple cracks at the same time. It responds to pressure. And then in thicker calcium, in longer lesions with vessel disparity, in bad EFs, IVL may be a good choice, but be careful, you need to get it to its site. And so the likelihood is you will end up using it in combination with a rotablation therapy or another therapy that'll mattify calcium to allow you to deliver. If you have a nice lumen there with circumferential concentric calcium that's thick, your IVL can become a very reasonable choice as well. Thanks very much for your time and attention.